Hi everyone, welcome. Thank you for joining this Target webinar today. I know we have a lot of people signed up and I think people are steadily joining now. We're really looking forward to an evening of lots of discussion. So my name is Kath. I'm a researcher and a project manager. I work for UK Health Security Agency and I work within the Target Antibiotics team. So this is our 10th webinar, I believe, in a series we have done with the RCGP. So this one is Navigating Antimicrobial Stewardship for New and Early Career Prescribers. And so you can find all our previous webinars on the Target Toolkit, and the recordings and slides of this webinar will be uploaded there as well in a few weeks' time. So I'm going to be chairing this session today, and I'll be introducing our speakers and panelists in a moment. The format will be the same as previous webinars. So I'll take you through some introductions of our speakers. Then our speakers will present for around 40 to 45 minutes, and we'll aim to have 15 minutes at the end dedicated to Q&A. So just some housekeeping. The chat function on here is disabled. So you'll be able to ask questions through the Q&A. So there's a Q&A box through Zoom you can use. Please ask questions throughout the presentation using the Q&A function. You don't need to wait until the end of the talk, but we'll pick up the questions at the end for the panelists to use in discussion. If you want to ask your question anonymously, please tick the anonymous box before submitting your question, and we'll aim to answer as many questions as possible in the time. Panelists can provide some written answers to questions as well. So as mentioned, the recording of this webinar will be uploaded to the Target Toolkit after the event, and you will be sent a link with a brief survey from RCGP directly after the webinar. So please do complete this because it really helps us in improving our webinars and also for suggestions for future webinars. There'll also be a link in that email to our next webinar, which will be on recurrent urinary tract infections, and that's taking place in March. Next slide, please. Just want to highlight some of the amazing Target and RCGP team who are responsible for a lot of the Target Toolkit work. And I want to especially thank Ming Lee and Camilla, who you won't see today, but they work really hard to develop and organize this webinar. Next slide, please. And also massive thank you to our speakers and panelists for supporting this event. So I'm going to ask them to introduce themselves now, one by one, if that's okay, starting with Harry.
Thank you, Kath. Hi, everybody. I'm Harry Ahmed. I'm a GP in Cardiff and a clinical reader at Cardiff University with an interest in common infections and antibiotic prescribing.
Hi everyone, I'm Linda Strettle. I'm a GP partner at the Village Surgery in Rotherham, and just through a variety of reasons I've made quite an interest in the Target resources, using them in practice, helping GP trainees to use them and people beyond that, so I hope you'll enjoy this today.
Hi, I'm Graham Dewes and I'm a GP in Macclesfield. I am the antimicrobial stewardship clinical lead across Cheshire. And I'm also a train the Target, trainer accredited trainer for the RCGP Target Toolkit.
Hi everyone, my name is Raji Dillon. I'm one of the consultant microbiologists at UHBW in Bristol and stewardship lead for the trust.
Hi everyone, so my name is Dr. Tayesi Adeniji, and I am a GP partner based in Northampton, and I'm also, the national chair of all First Fives for the RCGP.
Thank you so much, everyone. We'll go into the next slide, please. I'll just quickly talk through the aims. So this webinar, the theme was chosen based on feedback from user requests and participants of our previous events. And the aims are to discuss the burden and consequences of antimicrobial resistance for primary care, understand the importance of antimicrobial stewardship activities in your practice or setting, and also discuss how we can implement a cycle of antimicrobial stewardship activities. So Linda is very helpfully going to talk us through a real life example from her practice as well towards the end of the talk. Before we start, we'd just like to do a quick poll just to know a little bit about who's on the call and what your experience is of being a prescriber. So that should pop up in a second. There we go. I just wait for the results to come through. Great. Oh, so it's a really good mix actually, with majority more than 5 years. Great. Thank you so much for completing that. Finally, a quick reminder just to please send in your questions as you think of them using the Q&A box on the screen. And I'll now pass over to Harry for the first section of the talk.
Great, thank you, Kath. So just to reiterate, we're going to talk this evening about antimicrobial stewardship in primary care. And I think it's what we mean by antimicrobial stewardship. So NICE define this as a system-wide approach to promoting and monitoring judicious microbials to preserve their future effectiveness. So basically, antimicrobial stewardship is a key aspect of trying to reduce and stem antibiotic resistance. So before we talk about how we might navigate and visit of the antimicrobial resistance problem. So the data here are the most recent that we have really that explain that antimicrobial resistance is one of the top global public health threats. So on a global scale, AMR-associated deaths account for about 5 million. And AMR directly attributable deaths, where deaths are thought to be one of the primary cause, where AMR is thought to be the primary cause of the death, relate to about 1.2 million deaths globally. Now, the worrying thing is that over the next 30 years or so, these numbers are projected to increase quite dramatically. The problem more locally and more relevantly to us, if we think about deaths in England, AMR-associated deaths in England together account for more deaths than stomach cancer and diabetes put together. And AMR costs the NHS around about £180 million every year. So why is this relevant to us in primary care? Well, because we prescribe the majority of antibiotics in the NHS. So this graphic here shows antibiotic prescribing in terms of number of items per 1,000 head of the population. And it shows figures from 2014 right the way to 2023. And what we can see is that between 2014 and 2019, antibiotic prescribing actually dropped quite dramatically. And I'm sure we can all remember numerous initiatives that we engaged in to try to help this happen. Between 2020 and 2021, so the COVID pandemic, there was a lull in antibiotic prescribing, and that was likely multifactorial and changes in consulting behavior. And then in 2022, we see that antibiotic prescribing reaches pre-pandemic levels again, and 20 worry a little because it looks like antibiotic prescribing has increased. And although that looks like a small increase, what we're concerned about is that we don't want this to be the start of an upward trend, because we definitely don't want to undo the good work 2019. Now, the higher rates of prescribing over the last couple of years compared to 2000 impact COVID-19 had on antimicrobial stewardship efforts. So there was a recent qualitative study where primary care professionals were interviewed and asked and what healthcare professionals that to keep general practice operational during the pandemic and to try and cope with all the other demands that were put on primary care during those years. There was also reference to social and increases in remote consultations as contributing to making consultations more challenging, making it more difficult to assess patients who presented with symptoms of infection, particularly with such high background respiratory infection rates, and also changes in the threshold for prescribing antibiotics to try to prevent hospitalizations. However, we've now reached a period where we really need to prioritize antimicrobial stewardship again. And the key reason for this, as mentioned at the start, is because stewardship is so important for resistance. Now, we know from this meta-analysis, which was published in 2010 and has been highly cited since, that prescribing in primary care is directly related to your risk of resistance. So antibiotic prescribing for respiratory tract infections and urinary tract infections in primary care increases your risk of having antibiotic-resistant bacteria in respiratory and urinary samples for at least 12 months. But the risk of resistance actually goes beyond the individual who is prescribed the antibiotic. So this graphic shows findings from a UK HSA survey where the general public were asked that if they had taken antibiotics in the past 12 months for any infection and there were leftover antibiotics, what did they do? And I want to draw your attention to two specific areas. One is the proportion of people that say that they keep antibiotics to give to other family members if they become unwell. And the second is the proportion of people that say they just threw them away. And we need to understand what people mean when they say that they threw antibiotics away and how they disposed of them and what impact the disposal method might have had on other aspects of the environment that might contribute to the spread of antibiotic resistance. And this brings us on very nicely to the One Health approach. So One Health is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. And what the One Health approach says is that the health of humans, domestic and wild animals, plants, and the wider environment are closely linked and interdependent. So the One Health approach is particularly important for AMR because resistant organisms can spread quickly to animals, food, and the environment, making treatment of certain infections more challenging. So one key area where the One Health view is particularly relevant to us in primary care is discussing what people do with leftover antibiotics. So during those last few slides, we've covered sort of the background around the burden of antimicrobial resistance globally and more locally. And so we'll now move on to talk a little bit about antimicrobial stewardship efforts in your own practice. So just to revisit the definition of antimicrobial stewardship, so this is a healthcare system-wide approach to promoting and monitoring judicious use of antimicrobials to preserve their future effectiveness. So what can we do to try to address antimicrobial stewardship-related issues in our own practice? So you may have heard of TARGET. TARGET stands for Treat Antibiotics Responsibly, Guidance, Education and Tools, and TARGET has multiple resources available for primary care prescribers. Now, TARGET have developed this cycle of stewardship, which can be a good starting point to help implement antimicrobial stewardship activities in your own practice. The cycle of stewardship is a visual diagram of the antimicrobial stewardship process for primary care teams. It was developed with focus groups like practice teams and explored their current approach to antimicrobial stewardship, and particularly the facilitators. It's a step-by-step process that basically starts with identifying an area for improvement, using this to advance knowledge and learning in the identified area, and then using tools and resources to enhance stewardship, and finally reviewing the impact this might have had on antimicrobial prescribing. And primary care teams have reported that using this infographic has been helpful during practice meetings and training and development activities that are focused on antimicrobial stewardship. So we're going to move on to just going through each of these 4 steps in a little more detail. So identify. Step 1 is all about identifying areas where improvements are needed. In my practice, we recently did this step and we identified trying to switch people who are on prophylactic antibiotics for recurrent UTIs, for example, on antibiotic-sparing agents like methenamine hippurate or vaginal estrogens. So what resources are available to help you identify areas in your own practice where improvements might be needed? So 2 key things you can use. One is the TARGET self-assessment tool. So this is a short questionnaire for prescribers to assess their own antibiotic prescribing. It asks questions on what antimicrobial stewardship initiatives are in place, such as, do you analyze and discuss antibiotic prescribing at your practice and compare this to local indicators? Have you recently been involved in a practice audit around antibiotic prescribing? And this, in conjunction with practice meetings, can be helpful as a baseline and can aid discussions around areas to action or to introduce practices to areas that they want to act upon. You can also use data resources such as EPAC2 to benchmark your practices prescribing against local practices. To access EPAC2, you have to register on the platform, and EPAC2 then allows you to access dashboards and reports which can be customized for your ICB or your practice. The next step is to learn. So once you've identified which area you want to improve, refresh your knowledge and look for the latest guidance so that you can take action. So what resources are available to help us do this? So a key resource here is the Antimicrobial Prescribing Guidance by NICE. Target has produced a list of the conditions within the summary of antimicrobial prescribing guidance linked to all the available national guidance. You can also sign up for webinars or re-watch webinars. So for example, there's a webinar on how to manage UTIs that was hosted by Target last year, and it's available for re-watching on the site. Step 3 is to act. Now, this can sometimes be the most difficult step, and it really requires a practice-wide approach. Get everybody in the practice involved and engaged, everybody from the reception staff to the nursing staff to the GPs, everybody who is interested, get them involved and figure out a way that everybody can have a role to play in this so that they're fully engaged in the process. Ways that you can do this are Target produced posters that can be used, and practice staff, admin staff, for example, could be asked to put posters up in the waiting area and direct patients to them. During consultations, you can use leaflets to provide explanations as to why you're prescribing or not prescribing an antibiotic, and to provide self-care, prevention, and safety netting information to patients. It's important to review and manage adults on long-term and repeated antibiotics, as these are often a large source of prescribing, and some patients may be taking antibiotics longer than guidance advises. The Target How-To series aims to support primary care teams to review the appropriateness of antibiotics in the evidence-based treatment and prevention of conditions such as acne and COPD. A guide to recurrent UTI is being developed and will be available very soon. The last part of the antimicrobial stewardship cycle is to review, to see whether you've achieved what you intended to achieve and look at any impact or changes in prescribing that have occurred. Now, how can you do this? Well, a review may be conducted during practice meetings. It may be useful to redo the self-assessment checklist and reflect on what has changed. Conduct audits to see if prescribing patterns at your practice or region have changed. And this is particularly important if an audit was done at the start of this process to identify the area that you wanted to improve. All of these activities allow you to gauge whether all of this work that you've done has actually had an impact, and can also reveal areas where you can improve prescribing practices further. At the bottom of the slide, you'll see some resources that will allow you to get prescribing data of your practice and compare it to others. And you can explore these databases at your leisure. We previously introduced EPAC2, but there are others such as Open Prescribing, Fingertips, and Prescript. Just talk about each of these a little bit further. Prescript is NHS funded. It includes bulletins and briefings. It includes data to help commissioners benchmark their activity and identify where they can make the biggest difference. And they also include webinars to support learning on a variety of relevant topics. Fingertips, this is also open access, and it allows you to browse antimicrobial resistance indicators at different geographical levels. You can compare data against the regional average and export data to use locally. To access these data, you click here where it says AMR Local Indicators, and this resource is produced by the UK Health Security Agency. To find more information about resources that you can use, head on over to the Target website. The Target Toolkit consists of resources such as summaries of antimicrobial guidance, leaflets for patients, learning resources, audit tools, and can signpost you to other resources. The link to the site is at the bottom of the slide. The toolkit has now been available since 2009 and has been used widely by numerous prescribers already. So now that we've gone through the cycle of antimicrobial stewardship, we're going to talk very quickly about phase. Try to do this in your own practice. So we know that consultations around antibiotic prescribing and infection-related symptoms are really challenging. And one of the key challenges is navigating patient expectations. So a common reason why prescribers have said that they prescribe is due to patient demand and expectation. So this chart is pretty busy, but it shows some findings from the UK HSA annual survey with the general public. Patients who consulted a general practice for a respiratory tract infection in the last 12 months were asked what they expected from the consultation. And what they expected is shown in beige, and what happened is shown in white. And what we can see is through the pandemic, there was an increase in expectations across the board. But in 2024, we see that this settled back to pre-pandemic levels, give or take a few percentage points. So while there was an increase in those expecting antibiotics when they consulted in general practice compared to pre-COVID levels, there was also a marked increase in those wanting information on whether or not they actually needed the expected antibiotics. And this suggests that a patient that is demanding may actually just want reassurance that the infection has not gone down to the chest, for example, rather than antibiotics. I know we've all seen this, where patients come in and they say, I've had a cough for a week, please can you just check that it's not on my chest? Or, I've had a cough for a week previously, I ended up in hospital with pneumonia, can you just give me some advice about what I should do about it, etc., etc. Now, Target have created some additional resources that might help us during consultations with patients with suspected infection. And one of them is this CHEST SSS acronym that we can use to support these consultations. So CHEST SSS presents specific communication techniques that have been developed based on patient expectations. And importantly, these have been designed to be more specific to antibiotic discussions, so can be more useful and effective than traditional approaches that might be used, like, for example, ICE or the Calgary-Cambridge models. So what does the CHEST SSS acronym help us with? Well, in the first 5 minutes of the consultation, there's some key things that CHEST SSS can help us cover. So ask specifically about the patient's concerns, discuss the history and the examination. And sometimes this can be really helpful to provide a running commentary about negative signs and symptoms to reassure the patient. Ask specifically about expectations and provide a non-serious explanation for symptoms. And I think patients nowadays expect a little bit more than we think your symptoms might be related to a viral infection. And there's resources out there that can sometimes help us understand the prevalence of different circulating viruses, and a more thorough explanation about which potential viruses could be causing their illness sometimes is perceived better than just vague and non-specific symptoms about this being a viral illness. And then there's other things that CHEST SSS suggests that we do, but these can be covered in the patient information leaflets. And these are advice about the specific illness timeline and its usual course, i.e. the natural history, explaining why antibiotics might not be indicated and what the adverse consequences of unnecessarily prescribing antibiotics might be, advice about self-care, and advice about safety netting. Target also produced numerous patient information leaflets. This is the one for respiratory tract infections. As you can see, it provides the information as advised by the CHEST SSS acronym. This demonstrates how we can leverage patient information leaflets during consultations and empower patients whilst maximizing the amount of information we're able to reasonably provide in the short consultation time that we have. And we can access all Target's information leaflets via the patient information leaflet section of the Toolkit website. Now, another challenge that we sometimes have addressing antimicrobial stewardship is that we all get concerned about the adverse consequences of potentially not prescribing antibiotics. But there's reassuring data about how rare adverse consequences might be in certain circumstances. So it's been estimated that in a practice with roughly 7,000 patients, a 10% reduction in antibiotic prescribing for respiratory tract infection might lead to one additional peritonsillar abscess every 10 years and one additional pneumonia each year. So these are relatively rare events and might help reassure us when we're trying to weigh up the pros and cons of prescribing antibiotics versus trying to present an adverse consequence. OnTarget have also produced numerous other tools, as well as other research-related tools, that help us to understand the potential risk of adverse consequences or the potential benefits from antibiotics. So to reduce complications, consider using some of these diagnostic flowcharts and symptom scores. I'm sure many of us already use fever, pain, and star wave to guide our decisions on whether we should prescribe antibiotics at all, prescribe antibiotics immediately, or prescribe delayed antibiotics. And it can be really difficult having that discussion about whether to prescribe or not. And again, here, we recommend using some of the target leaflets to try and support the decisions that we make. So that was an overview of antibiotic resistance and what we can do to implement antibiotic stewardship related activities in our own practice. And so I'm going to hand over now to Dr. Linda Strettle, who's going to talk us through how they implemented a cycle of antimicrobial stewardship in their own practice.
Next slide. Thanks, that's great. Thank you so much for that. So hi everybody. Developed in this from a problem originally. So the first problem that we had in a practice I was working in previous to where I work now was about urine, and I'm sure you've all experienced the many urine samples being dropped off and without a reason and without the detail, and then the risk that carries of the wrong diagnosis and the wrong treatment. And so all of this kind of started from originally having that, what on earth do we do with all these urine samples? And it's gone on from there. Various different areas that I've looked at, but I wanted to show in this part of the presentation how that cycle that's been described can really help improve so many parts of the day-to-day work that we do, actually, because it's not necessarily just about the antibiotics, it's about the processes that are happening in practice and getting everybody in the practice on board with it, because actually you can use that process with everybody involved. The example that I'm going to talk through now is like a part of what we've done, and I'll talk through the details of what happened. If you could switch to the next slide, please. So the problem was identified really at the surgery that I worked at when we were asked by the local medicines management team to look at the STAR PU prescribing, because as a practice we were above the local prescribing target in the 2022-23 year. So it's a weekend I'll never get back, but I looked at all antibiotics that were prescribed in the highest month of that year, which was June 2022. I wouldn't suggest that anybody needs to do that level of detail, but I just really wanted to prove to the medicines management team kind of what was going on and that we were actually doing okay with our kind of prescribing at that point. Now, what I would suggest is if you are interested in doing these kind of things is start small, start with something simple, find the problem. So is it that your practice is really struggling with loads of upper respiratory tract infections or lots of UTI prescribing? Like, where is there a lot of prescribing going on, or where is the thing that is annoying everyone? So the urine samples being dropped off, or people not knowing when to prescribe antibiotics, or lots and lots of trimethoprim being issued. So find where that problem is. As part of the review, what I did is I looked at the antibiotic stewardship tools and audits on the Target website, which you can see on the left box there, and I audited for different groups on those audits where the practice was at that point. So, and those are just a little bit of the results of what was given. So that was identifying where the problems were. So actually on acute cough, we were doing quite well, but maybe on rhinosinusitis, we weren't doing so well. And in UTIs, we were doing kind of average. So I identified some areas where perhaps we could look into things. Next slide, please. And then it was looking at all the things on the Target website. So as we've just looked at the antimicrobial prescribing guidelines, so what is the prescribing guidelines? What does CKS have on it? And then looking at the toolkit hub there, which also has all that stuff about what information you can give to patients, all the information about the guidance and kind of webinars available to try and get your team involved and refresh the knowledge. Please. And then it was about what to do. So I'm sure most of us work in big teams or bigger teams, and just having one person going and doing the Target work is not going to fix it, as I'm sure we're all aware. So it's about somebody in the practice really getting involved and getting their teeth into this and getting some enthusiasm, and then trying to get the rest of the team involved. So I'm a Target trainer, which is quite simple to do. It's a course that you do with the Target team. but there's loads of resources even on the website for whichever area you might choose as a practice to look at. And as part of that, what I did is I took the general information, some of the stuff we've discussed today, you know, the use of antibiotics and the problems it will cause, and I adapted it to our practice with some more information about where the issues were, you know, where we weren't following the guidelines, where we could improve. So example, when I first joined the practice, there was lots of 5 days prescription for UTIs being given instead of 3 days. There was lots of trimethoprim prescribing rather than nitrofurantoin for UTIs. So I did a across the practice feedback protected learning time event in a webinar presentation. I also did a global antibiotic kind of little newsletter for everybody, and I also gave individualized feedback to clinicians so they could benchmark themselves against others. Now that's obviously quite a lot of detail, but it really did make quite a difference, because I think some people didn't realize that they were outliers, so they were maybe prescribing more antibiotics for UTIs. We also looked at things like how many of the urine samples that were given antibiotics actually came back as negative. So were people, you know, jumping in with antibiotics where they could have said to the patient, you know, wait a few days, let's wait for the urine result first. And giving that individual feedback really made people think about what they were doing in their consultations, which was helpful. So we fed back across the practice and to each individual. And I think the key to it all was getting everyone involved. So it wasn't just the clinicians who are prescribing we got involved, we've got the nurses involved. In our practice, we have nurses who do triage. So we got them involved in the flow charts. So they actually now look up the flow chart as well as they're doing their calls to the patients. So they can almost predict what the doctor might do as a result of that. We also looked at the amount of urine dipsticks we were doing. Again, in over 65s, it's not recommended to do a urine dipstick for a UTI. So we made sure that everyone was aware of that. And then we also got everyone involved, including even the receptionists, on we only accept urine samples if there has been a clinical consultation first. And that tries to get rid of the random urine being dropped off at 5 o'clock on a Friday and you don't know why it's there. Because once you've got the sample, you're a bit stuck as to what you do with it. So we had to involve everybody, and actually that made it quite interesting. I think urine's not always that exciting, but actually if everyone's involved in it and engaged in it, it makes the answer back to the patient if there's a problem much more streamlined, because everyone's saying the same thing of, we need a urine sample first, we need a consultation, this is the duration of time that you'll get your antibiotics for. So you're not then getting, you know, that confusion and uncertainty. So we got everybody across the practice involved, and we really got everyone engaged in it. Next slide, please. And then we looked again, so we used the same audit again, and I need to say thanks to Dr. Zoya Sharia, who's one of my GP trainees in the practice, and she kindly re-audited the prescribing 2 years later to see where we were. That was done in September last year, 2024, to see whether it had improved. And actually we were improved, so we had improved on our prescribing rates, so that was appropriate antibiotics for appropriate durations, so that was a really good sign. And actually you can see, if you look on Open Prescribing or any of these websites, you can see when the work was done, because our 5-day prescribing of UTI antibiotics suddenly drops. So people really did take that on board, which was nice. We are a real life general practice though, so actually if you look on the Fingertips website, our total number of antibiotics on the STAR PU, which was one of the reasons we've done this work to start with, is still about, so we are just sitting above the average. So it's real life. We have a lot of trainees, we have a lot of additional roles, scheme people, we have a lot of people coming and going through the practice, and it is hard to keep this stuff going all the time. But I think if you start with a small area, pick an area that you're interested in, or where there's a problem or where you think there's an issue, use the target kind of information and audit to look at what the problems might be. It can then at least work on some area, and at least you can show some improvement. So I suppose the message is start small, find something that's tricky and difficult in your practice, get everyone involved. And actually it does make your day-to-day life nicer and better, because everyone knows what to do in certain situations. And I think that's me. Thank you.
Thank you so much, Linda, and thank you, Harry. Just before we go on to the Q&A, I just want to acknowledge our colleagues who have helped with the slides. And then the next slide just to have a quick plug for the survey that you'll receive just after the event, and we'd really love to hear what you think, but also what future topics you'd like to hear from us. And again, the UTI recurrent UTI session is on Wednesday, the 19th of March, and you can sign up for that on the Target Toolkit as well. So we'll take down the slides for now, and we'll go on to the Q&A. So thank you everybody for sending in your questions. If our panelists just want to put on your cameras, ready. Excellent. So we've got a couple of questions. I'm going to go to maybe Raj first, just to give Harry and Linda a break. So Raj, I know you've answered this in the, you've done a written answer to it, but just if you'd like to speak to this a bit more, it was around someone was interested in the mislabeling of penicillin allergies for children who have GI symptoms, and how can we educate parents and staff around this?
Yeah, so it's a very important kind of concept to try and get in our heads, is basically discerning between intolerance and allergy. GI symptoms can be a vast array of things, and it can be associated with antibiotic use, but more of an intolerance, and you can't really label some, or you shouldn't label someone allergic on the basis of just gut intolerance. Now, in terms of resources that you could use to help educate staff and parents, I'm not sure what there is in primary care. But certainly in secondary care, whenever we get patients with these kind of circumstances, we just don't label them pen allergic at all. We just say it's an intolerance. We'll try and give you some anti-sickness stuff while we'll give you the appropriate antibiotic. And in terms of the viral question that was added to that, again, there's a lot of resource from hospitals, especially pediatric centers, that have very good kind of leaflets and stuff on their websites. So Great Ormond Street and Alder Hey and all those kind of hospitals that have pediatric centers that have very good resources in terms of the common things to look for in terms of viral skin changes, which again wouldn't be antibiotic related. But again, I'm not sure in the primary care setting what kind of resources there are surrounding the kind of viral exams.
I think also, just coming back to the penicillin delabeling, there's likely to be increasing guidance coming out for primary care, because for those very likely penicillin allergies, the ability to refer for testing is going to be, I think, increasingly available, particularly in sort of pediatric services. And there's obviously really important reasons for those, because when you can't have the antibiotics, the likelihood of going on to broad spectrum or sort of the so you know the quinolones, for example, the risk of that goes up. So I think where there is a genuine concern that a patient has true anaphylaxis, then without doubt they should be being referred and assessed. Sometimes it's a quite laborious notes review. Often patients say there's a family history, and actually the family history is often unhelpful because that rash as well and may not have been antibiotic related. But I think, as I say, I think there will be more resources coming through to support appropriate delabeling or confirmation where appropriate of penicillin allergies.
Yeah, I just want to kind of echo what you said there. And then certainly in secondary care, we're trying to get services available to do penicillin delabeling, and who takes responsibility for that when patients get referred in. And it's essentially the cases that are in between the true kind of anaphylactic documentation of an allergy, which you can't really delabel, and the ones that you can delabel and just symptoms alone, so like intolerances. And as you mentioned, family history. So family history isn't a factor, so they can be delabeled on the basis of that, because there's no hereditary link for penicillin allergy. So So you can delabel them based on symptoms alone. You can't really delabel, obviously, if they've got a true anaphylactic or documented anaphylactic reaction, but it's the ones in the middle, the kind of non-type 1 reaction, skin rashes that they've had as a child, and then going into adolescence and adulthood, that we're trying to kind of target and see if we can get a system in place to delabel them in a safe setting, because obviously you can't do that in GP, in primary care.
Thank you both. We've had a few more questions on penicillin allergies actually once you've been speaking. I think you might have answered one of them. It was, is there a hereditary link in families? So
yeah, no, so that we do see that quite a lot. So oh, my mum had a reaction to penicillin when she was fine, then you can be delabeled. So in that kind of I mean, so there's no hereditary association. I can't see what the other questions are.
The one was, is the PenFast score useful for determining risk of penicillin?
I think so. I quite like that a lot. So that's the MD Calc PenFast tool that's widely available on the internet. I quite like it. I think it's really good, and I do recommend that to quite a lot of healthcare professionals.
Thank you so much. So we'll go on to another question. This might be a good one for the GPs. How do we find time for AMS activities with a very busy working day? So maybe Harry and Toyosi may like to come in on this one.
Yeah, I think it's challenging. It is really challenging. But I think what Linda was talking about is really important, and that's getting the whole practice team involved so that the burden doesn't fall on one specific individual. You know, if you need to do an audit, have you got medical students who are in the practice who might be interested in doing one? Have you got trainees who need to do one for their appraisal folder? In terms of, the step 2 of the cycle, the knowledge cycle, who is best suited to do that? Have you got academic GP trainees in the practice, or have you got other links where people might be able to help identify appropriate resources and help the practice undertake those activities as a team? So I think it's sharing the load. And we know that there's huge amount of general practice at the moment from all aspects. So I can totally understand why people think, oh, well, I don't have time to do this. But I think it's about sharing the load, involving as many people as possible, and doing it as a team.
And just to add to that, I completely agree. I think it's important to have the buy-in of everyone, even those in senior leadership within your practice. So if you explain what what the vision is, I'm sure most people understand this is quite an important matter, and I'm hoping they'll be able to dedicate that time, be it in something like PLT, like Linda said. That is a fantastic opportunity to use. For those of you in fellowships as well, whether fellowships via ICBs or, whatever fellowships, those dedicated times for projects, that's something you can do as well, really. And when we talk about the PLT side of things, I think it would be important to leverage on using it as important education. That is doing things like simulations. And this would tie into one of the other questions in terms of people feeling confident enough to, say no. I think, yes, people, there are resources out there for you to use, engage with them. But beyond that, getting into simulated environments to practice, that negotiation is actually important for the patient to understand why they do not necessarily need that antibiotic in that moment. So practice, and for those of you that have got exams for the registrars in the room, it's also good, for practicing for your consultation skills. So yes, the time will come.
Thank you so much, Toyosi. There's a question around fever pain and Centaur. So what is the evidence behind fever pain? Is one and Centaur, is one better than the other? And then they said that I've met a few GPs who will only prescribe antibiotics if they see pus on the tonsils. I wondered if maybe Linda or Harry might be able to comment on this one.
Generally, I think Centaur is older and fever pain has more evidence behind it. I have to say, I don't know the background to that, but that's just what I remember from training. So I tend to use fever pain. And I suppose about the pus on the tonsils, well, it is part of the questions, isn't it? I suppose if there's not pus on the tonsils, then you need to have a very good reason to believe that it's tonsillitis over something else. And I tend to use those scores within the consultation. So I actually get them up on the screen with the patient at the time and say, okay, well, let's look at this score together. Because then actually, if it does come back as a fever pain of 0 or 1, you've got a clear thing in front of you saying this is not tonsillitis or it's not bacterial tonsillitis, and then actually some of the tools that you do it on even say then the percentage of strep will be this on that tool. So then you can say to the patient, well, this is what your symptoms are, this is what they fit into this score that we've got that tells us about the chance of it being a bacterial infection, and this is why it may not be a bacterial infection. So I suppose the way I use them is more as a tool with the patient now. And if the fever pain score is low, I think then you can really engage the patient in that discussion of, well, these are the risks then with antibiotics, and this is why it's not recommended in this situation. So I suppose you can use antibiotics in what's suspected bacterial tonsillitis, but I suppose the fever pain score will be inherently then lower, and you may want to then discuss the other options with the patient, such as delayed prescribing or making sure you're not missing another cause for the symptoms actually at that point.
I think that's a really good practical response. So just echoing a little bit on that. So previously someone said, how can you find time to do sort of antibiotic training within the practice? And I think really there's the point that it's so important that you do find the time because it will benefit you as a practice overall. So if you are providing consistent messages to patients across all types of health professionals, then the patients aren't going to necessarily pick and choose or come back for a second opinion. Also, it is well known that if you give an antibiotic once for sore throat, cough, earache, then you've set an expectation. And so patients will often say, well, I don't understand why you're not giving me an antibiotic because Dr. Jones gave me an antibiotic. And I think you have to say, well, I am prescribing or not prescribing on the basis of the clinical assessment today. Obviously, you do have the target toolkit leaflets to hand out. In children, you've got leaflets such as when to worry. But I think it's really important, I think, that as much as you can, you expose yourself to some of the education that is available on target, because when I think patients will challenge you at times as to say, well, I think I need an antibiotic. And I think, you need to be able to have the confidence, which comes from the education, to say, well, actually, I hear you, but let me explain why, in this case, an antibiotic isn't needed. And I think if a patient gets a confident response, it doesn't become a challenging consultation, and you've educated them for the next time.
And I think following on from that, there's a whole webinar about delayed prescribing of antibiotics from Target as well. And that is another way of approaching those consultations, isn't it? Particularly if you get a very, very angry or negative response, or the expectation is so high for antibiotics. And there's different ways to do delayed prescribing of antibiotics, and it doesn't necessarily mean you issue the prescription there and you can get them to call back. You can send it to the pharmacy but tell them not to collect it. And there's a range of different ways to then do that. And there's evidence that if you do delay prescribing, a decent number of patients don't then pick up the prescription, don't take the prescription, and then also don't expect it the next time. So that's also kind of a middle ground. And just following on from the how to find time for this, well, as we've all discussed, I mean, it's really important for this, but actually it's saved time overall with us all having the same message. So I think if you do get everyone on board and the nurses are doing the same things and the doctors are doing the same things and the receptionists understand what's being done, that it does save time overall, because everyone's singing from the same hymn sheet as such.
Thank you so much. There is a really interesting question. I think, Graham, you might like to take this one. It's around, are there any resources for assessing patients remotely via telephone consultation to decide if antibiotics are indicated? Or would you advise always assessing patients face-to-face?
It's a fantastic question, and I think there's not necessarily an overall sort of way to respond in it for every situation. I think, however, most acute infective processes are beneficial by having an examination. So sore throat, you need to look in the at the throat, assess the tonsils, but also obviously things like fever, pain, ask if there's any cervical lymphadenopathy and whether there's any temperature. And I think, for example, a lot of patients say, "Oh yes, I've been hot," but that's different from actually measuring a temperature. If you're looking at obviously cough, then you would need a chest examination, earache to look in the ears. So I find it's very difficult to assess these patients remotely. And I think by and large, it's really good to have a policy whereby the practice, maybe even on the website or at least amongst the prescribers, say, you know, we will not be prescribing antibiotics remotely. Because I just don't think you can have that full clinical assessment. Interestingly, on that note, we used to prescribe the so-called rescue packs for COPD when people had exacerbations. But we knew that people were probably not using them appropriately. So they may have been having antibiotics when they only needed steroids, steroids when they needed antibiotics, or probably they didn't need any escalation at all. Actually now remove rescue packs from all our patients with COPD because we're saying actually it's much safer to have a clinical assessment. So I think there is the risk of missing something, and therefore you should get patients in. We are a triage practice, so patients send in their clinical query, and then because it's still triage, the doctor will respond. There's an increasing, I suppose, request from patients that, oh, can you just text me a reply, or can I just have a phone call? And I think that's very difficult because, you know, people struggle to get out of work. And, you know, we'll book face-to-face appointments and patients will ring up reception and change them, and he's suddenly having a phone call. And I think the answer is, you know, often I would not feel comfortable prescribing and still end up bringing that patient down. So I think face-to-face should be your go-to.
Just adding a slight change, other option as well, though. There's one thing where I think text messaging and phone ones does work is younger women with UTIs. So yes, I totally agree if it's something like a chest problem or so on, but a well person, a young person with a likely UTI, if you have access to Accurx, the text messaging system, there is a target UTI flurry you can send, which automatically pre-populates all the appropriate questions that link directly into the target flowchart for treatment of UTI. So it gives you everything, including whether they are at risk of pregnancy, including whether they have symptoms of other more serious conditions like sepsis conditions and symptoms. So that is one actually where maybe remotely it can work. And actually, I can almost completely do that without speaking to the person. So send them the flurry, it has all the details in, ask them to bring in a urine sample. And then as long as it doesn't need a dipstick, so some patients don't need a dipstick according to the target flowchart, then you can then send them back the target antibiotic leaflet directly. And I add to that pre-made text message on Accurx, the UTI one, you know, your antibiotics have been sent to the chemist for a 3-day course and so on. And the leaflet that goes with that does then say all the stuff about your symptoms may not have resolved by 3 days, but, you know, these are the things you can do and try and when to seek advice. So that UTIs in women, particularly under the age of 65, it can work really nicely to do that remotely. But yeah, I agree with the other ones, throats and chests. You need to listen. Look.
Thank you so much, both of you. So there was another question that I believe, Linda, you did a written response, but it might be, you and others might like to just talk to it a little bit. So it was, someone was interested in how to support new prescribers in AMS, particularly for nurse prescribers, where they've seen frequent reports that they feel pressure to prescribe antibiotics where it may not be necessary. So is there anything Linda or others might like to add to that answer?
So I think that question came in relatively early during the talk, and then actually there was quite a lot more information that Dr. Ahmad mentioned about that kind of approach to the consultations, really useful. So that kind of data gathering, but then spending quite a lot of time at looking at, well, what symptoms and signs do you have suggestive infection? How likely is that to be a bacterial or not infection? And then sharing the rationale for prescribing or not prescribing. I particularly like to share the risks of antibiotics, because I think we probably in the past have undersold that. So every time now I prescribe an antibiotic or talk about antibiotics, or there's antibiotics mentioned, I say, well, these are the problems with them. One of the phrases I find really useful and helps people to think about it is, I say to people, remember when COVID first started and we had no treatment for it? If we carry on using antibiotics when we don't need them, we will have many infections we can't treat. And people, it's less in the front of their mind now than it perhaps was. But still, people remember how horrible COVID was when it first came and we had nothing to treat it with. So I think making it real to that person, and that you're not just being difficult, or it's not a prescribing target, or it's not a money-related things. I think people still think that we're prescribing because it's going to cost the practice or cost the NHS and things like that. And making it real to that person of, you in the future will have resistance, you will have issues. So that kind of stuff, and helping the person feel empowered to have that conversation. Ways to gain that knowledge, I suppose, is through, so there is a webinar specifically about having conversations about antibiotics and difficult consultations, and then helping them develop those skills of sharing their decision making, so why they think that antibiotics aren't required, because that is quite a hard skill to go from taking a consultation, having a plan, to taking a consultation, having a plan, and sharing that kind of discussion that they've had in their head with the patient in a way that then the patient feels they've been listened to, but equally the outcome is whatever it may be.
The one thing I would add to what Linda says is, don't be afraid to go and ask colleagues for some help. These consultations are really challenging, and if you've got a challenging consultation, knock on somebody's door, explain the story, review the patient together, and have somebody in the room supporting you to reinforce the message that you have given. And although it seems like an inconvenience, and that you're adding time to other people's workload, actually in the long run it will save time if it prevents people from coming back unnecessarily. So yeah, don't be afraid to ask for help if you're feeling like you need additional support in any of these consultations.
And I was just going to add that with the role of clinical, physicians associates and probably clinical pharmacists as well, to be honest, through the R's roles, that we really are ensuring that every consultation is now supervised to try and provide the education for and appropriate level of clinical support for colleagues as well. And I think over time, you will learn. I think you learn on the job, but I think it's also because you might not be learning the right things. I think also, for example, all the resources on the Target Toolkit are really, always something you should go back to, looking at nice clinical knowledge summaries as well, of course.
And just to add on to what everyone said, really, I think I'm now thinking out of the box, thinking outside the clinical room itself. If you do get the opportunity to engage in projects, thinking about creating leaflets or communicate things, information we can spread out to communities that, for example, English isn't first language, or communities that would struggle to understand, the standard leaflets we've got at the minute. Are there opportunities to educate people in communities outside? I think we need to get that conversation started as well beyond our clinical rooms.
Thank you so much. So there's one last question and we'll finish off for the day. It was, where can I find details of locally circulating viruses? Did anybody have a thought around that one?
The Surveillance Centre host a platform that provides some information. I can't remember how fine-grained the information is, but it definitely has some information about positive test results within geographical areas for viruses and other things.
Yeah, and your local, sorry, public health team will have surveillance data for your area. So if you could just email them or call them and get that data if you wanted it.
Brilliant. Thank you so much, everyone. And we're up to time now. Perfect timing. So thank you to all of our speakers and panelists. And thank you to everybody for joining today. And have a lovely evening.